technologists have to improve it. This is a patient who has cirrhosis of the liver, and he has developed this very nasty hepatoma, it's called, liver cancer. And despite using a probe, which has 3 probes at once, it is very difficult for me, unless I put several implantation, to really destroy the whole tumor. And we need new types of laparoscopic in situ ablation that conform to the size and shape of the tumor. And it's very important that the engineers see these videos to see the problem that we have. It's even influenced transplantation. I'm going to show you another video. This is from Pisa. This is from Pisa. It's obviously abridged, but a little incision is made. And this incision is for eventual removal. The donor kidney has been isolated, as you can see in a minute. And this is the mother of a young lad, aged 22, who was also diabetic with end-stage renal disease and required a pancreas and kidney transplant. And again, another type of technology developed, a vascular stapler that staples and cuts, has enabled us to do this operation. Now, this mother would be in hospital after giving her kidney to her son for 3 days. She would have a little scar, perhaps 3 centimeters for removal of the kidney ring. And because we are stopping the blood to the kidney right only at the last, the important period of warm ischemia, which damages the kidney, is kept to a minimum. And as soon as it's the last cap, it's put in the bag, and the only difficulty is getting the kidney out, unless you want to make a very big incision. And immediately it's cooled. What has happened, certainly in Italy, there has been an increase of 25% in people offering to give their kidney to their relatives undergoing renal transplantation. Now this is, to me, again, a recognition of immense value. And likewise, major pancreatic surgery can be carried out, and the technology continues to evolve. This idea, to me, that the surgeon will operate looking at a monitor and stretching his neck, and very often they pain in the shoulder, is ergonomically wrong. And we spent a long period of time to replace, and this is the latest, so we now are getting rid of monitors and televisions. And the image from the camera is projected on top of the patient. And with the advent of OLED technology, this screen will be just a thin sheet of plastic. And the other important thing is because it's now on top of the patient, it makes the operation easier because the surgeon can actually now see his hands. so that the visual and the effector axis are realigned. And again, this is an example of what I call the systems engineering or ergonomics approach. And it's gone on, and this is the latest Da Vinci. It has 2 consoles now, and 4 arms, 3 for the manipulators, and 1 for the camera. The only problem, I think, with this robotic technology is for too long there's been a monopoly just of one company. But that is likely to change fairly soon, I think. This is a Masterslave manipulator. It basically consists of the Masterslave control with 2 subsystems, the surgeon's console and the patient's sidecar, which carries the manipulator arms, which follow very closely the movement of the surgeon's hands in the console. The surgeon is now operating seated comfortably at a distance from the patient, manipulating the robotic arms. And instead of using the hand, now he uses just the finger, the index finger and the thumb. So it's finger surgery, so precise. And the reason for the great dexterity is this internal wrist, which gives 7 degrees of freedom. This is what I downloaded this from the internet. No human hands could do that. That's an origami done by the robot. And it illustrates, in my view, the precision that is possible with this robotic assisted surgery, which, however gifted a surgeon is in terms of that, he can never achieve. Never. And he can toggle between 2D and 3D vision. The image quality is superb. And he's using his 2 hands. Well, it's not hands really, as I said before, an index and thumb to do the manipulation. I can assure you, if I do a robotically assisted pancreatectomy, I am much less tired than if I did it without. No question whatsoever. And also, it reduces the technical difficulty of the operation completely, which means that it's easier to do, it's safer to do. In Pisa, we have been very interested in the development of augmented reality, what we call computer-assisted surgery. In this setup, the patient information obtained by the CT is segmented with 3D reconstruction of the topographical anatomy of the lesion, whatever it is, its exact location, anatomic relationships, etc. And then the images are registered with any patient in the OR using motion tracking system. The surgeon wears a special helmet which enables him to see both the augmented reality and also the patient's actual anatomy. This is an example of, this is a patient with a splenic artery aneurysm. This is a condition that affects women for some reason only, or largely. And when this aneurysm, dilatation bursts, the woman dies usually. And here we have the imaging of this dilated swelling of the artery. which is done by the engineers at Endocast, and this is the patient's segmented anatomy. This is the splenic artery, this is the aneurysm, that's the spleen, the yellow bit is the pancreas, etc. In the operating room, once it's all done, the surgeon wears a special helmet. And the image is projected and registered with the patient. So it's like painting by numbers, almost. And for difficult operations such as this or difficult tumors, in my view, it's a very significant advance. And this is the actual anatomy. And with the robot, he can start a dissection and dissect all the branches coming from and to this aneurysm, and decide and find the one artery. There's only one artery that has to be joined up again. Otherwise the spleen will die, and we'll have to. And this is where this computer-assisted technology is helpful. Notice the lack of tremor due to the motion scaling. So the surgery by the robot. So the surgery is precise and deliberate. And you can do work, fine work, which is not possible without the robot. And at any time he can refer back to the image to guide him. For example, on the image he's putting clips to see if the spleen is perfused or not. In other words, he can decide which vessels can be tied up until he identifies, with the help of this segmented or augmented reality, which is the one that he needs to preserve and rejoin again. Now he has identified the vessel that needs to be joined up again. Now this vessel would be quite small, about 3 millimeters. And if we are to preserve the spleen, or part of the spleen, we have to join that up. The others we can tie off. And again, the robot assistance allows this delicate microvascular anastomosis to be performed with relative ease, I might say. And now he's completed the anastomosis. We're checking with an ultrasound, laparoscopic ultrasound, that the kidney was black before is now revascularizing, and he can now, he's tied everything and open this aneurysm, as it's called, and check that there are no branches left, there's no bleeding this time. So he's done a successful operation, in my view, considerably facilitated by this technology. So what is the role of engineering in cancer therapy? I've summarized, in my view, of the role in this slide. Diagnosis, imaging and staging of cancer, advanced technologies for minimal access surgery for cancer, technologies for in situ ablation, medical biophotonic technologies, technologies for treatment of disabilities caused by cancer or its treatment, and immense potential in nanoengineering. These are examples of the imaging. Now we have 3 Tesla MRI, which is showing immense detail of tumor. It's creating actually some problem because some lesions are being diagnosed in the breast, which nobody knows how to treat because we don't have the information. That's scanning and more recently photoacoustic imaging. In situ ablation by high-intensity focused ultrasound. Great interest to the MRI ultrasonic physics groups at IMSAT. This is another development, outpatient photodynamic therapy based on organic light emitting diodes. Basically, this ends up being a plaster with these light emitting diodes for the treatment of skin cancer. The patient doesn't need to go in hospital at all once the diagnosis is made. And of course then we have nanotechnology, which we will discuss tomorrow. In my view, there will be a new era characterized by advances in nanomedicine. The EU nanotechnology platform has identified these disorders which the EU thinks will be considerably improved the outcome of. And one of these is cancer, has been identified as one major disease which will benefit from advances in nanotechnology. So we need a holistic approach, in my opinion, to the cancer problem. The disruptive breakthroughs too will come from life sciences. But we mustn't forget new disruptive technologies and of course the systems engineering approach is also essential. In my view, and this is my concept and I come back to it, I believe in what I call interface of science, where the life sciences and the medical sciences are working in shared environment with the physical sciences and engineering. And this is what interface science, it's different from multidisciplinary science. These people are working together in a shared laboratory environment. They learn each other's language. They learn to speak to each other. The clinicians identify the unmet needs which the technology has to do. If we do this, in my opinion, then we think that the delay in this delay here, and this is my last slide, which on average from concept to realization and introduction in clinics in average 15 years. I mentioned that as far as keyhole surgery is concerned, it's 40 years. That period can be short. Thank you for your attention.